Hi, my name's Dr. Ed Home and welcome to Sick Notes, where I explain medical things in simple terms. I've just finished watching the first episode of the new hit medical TV show to hit our screens, The Resident, and it was full on. I mean, pretty much every doctor, I think bar one, would have been struck off and maybe even go to jail based on their actions of the first episode. So this is certainly the most kind of thriller-like of any medical show I've seen, with the doctors at the sort of centre of the controversy. I mean, the last scene is so full on, I could barely watch it. But anyway, along the way there were some really interesting medical cases. Quite a few of them popped up actually. As with all of these medical shows, clearly it's not supposed to be realistic, and this is just a light-hearted way to share some of my experiences and give you a little bit more information of what's going on the screen. Obviously there's going to be loads of spoilers throughout this, so if you want to catch The Resident, then I'd recommend taking a look at it. So let's crack on and watch The Resident.
Bill, yank that sucker.
No, the appendix hasn't burst. That's good news.
So the first operation when I look back at Grey's Anatomy was an appendicectomy, so a really common case, and this is pretty realistic. We see a lot of them. Just to remind you, the appendix is this blind-ended piece of gut that we no longer need, and it's because it's blind-ended, it's not part of the flow really of the gut, so bacteria and food can build up there, and that's why it can be a source of infection.
Oh, we're just having fun. He's out cold. He'll never know.
Wait, I'm gonna take a quick selfie.
Taking a selfie in an operating theatre. What? This is a massive breach of patient confidentiality. You only need to do a quick Google search to see what I mean. So I'm sad to say that this is pretty realistic because it has actually happened. Arterial blood is under high pressure because it essentially comes straight from the heart. So this spraying everywhere is completely realistic. When this happens in theatre, you need to get the sort of surgical field clear as quickly as possible with swabs, suction, and get a clamp on where the blood's coming from. One thing that is nice to see actually is the anaesthetist or anesthesiologist managing the patient's vitals. So often in these medical dramas, it's the sort of surgeon operating that is kind of looking at the blood pressure and giving, advice and things like that, but actually the anaesthetist is the one that's keeping the patient safe and stable from that point of view, meaning the surgeon can focus what they're doing in the operating field.
Call for 4 units of blood and 2 FFP stat.
We see a change of gear here as they identify an issue, blood and FFP stat. So we want to be careful not just giving the patient loads of fluids if they're bleeding. The kind of old adage goes, replace like with like. Obviously when people lose blood, their blood pressure drops. We can't simply give fluids because fluids dilute the red blood cells, so we lose the ability to carry oxygen well, and also we don't want to dilute the clotting factors, so that's why we give red blood cells to replace the red blood cells we're losing, and we give FFP, so fresh frozen plasma, which contains all the clotting proteins. As the name suggests, fresh frozen plasma is frozen, so it takes around 30 minutes for us to thaw it out and get it into the patient. And the blood as well, although often in theatre we have some O-neg around, it can often take sort of 20-30 minutes if it's not on standby. So now you can see if patient's bleeding drastically, why it's so scary. So the patient goes into a cardiac arrest, so when your heart is functionally stopped due to blood loss. Anaesthetists are experts at running these, and even though they're in theatre, a cardiac arrest call should go out. There's a certain amount of human factors at play here watching this back. I mean, the surgeon should be focusing on stopping the bleed, and maybe one of the other scrub nurse should be doing the CPR, as presumably the artery is still bleeding, so if they don't fix that cause while someone is trying to maintain some circulation, the arrest is going to be futile. They then lie that the patient had a heart attack rather than died from the mistake in theatre and the blood loss, and this show is clearly highlighting how it is wrong, but still pretty painful to watch. Okay, so then we lighten the mood a bit. So we meet Dr. Pravish. So he's the new intern about to start, and this is pretty embarrassing. I think as med students, we've all done this.
Clavicular head. The sternum.
So try out bits of anatomy on our significant others. I think as a med student, you're just so super proud that you're learning things that you just kind of want to show. It's not really showing off, it's kind of just over pride really. So I think med students, we love to talk about you know, what we're learning in medicine, and also we love to put our profile pics on social media of, you know, us in stethoscopes. I remember even when I washed my hands, the thing we first learned on the first day at medical school, I just couldn't wait to show everyone how to wash their hands properly. So Dr. Pravish, the new intern, meets Dr. Hawkins for the first time, his resident, and we see Dr. Hawkins has a tattoo of the rod of Ecclesius. This is kind of a symbol of medicine, if you like, based off I think the Greek god of healing. I've actually seen this tattoo on a few doctors before. People, as I said before, you know, a lot of people are very proud of what they're doing in medicine, so this is kind of a symbol that a lot of people use. Lots of tattoos I've seen on doctors, you know, good and bad.
Dr. C.
Over easy, no cheese, no mayo, breakfast sandwich.
Good man.
By the way, this is exactly how I'm like in hospital, you know, strutting my stuff, high-fiving people, people giving me sandwiches, 100% true. So the first patient they see has CAUDA EQUINA syndrome. So did you know that your spinal cord doesn't go all the way down your back? In the lower back, the actual spinal cord turns into just a sort of horse's tail of nerves that we call the CAUDA EQUINA. Quite literally means horse's tail. So this is our spinal cord. Here's my spinal cord, and here's the CAUDA EQUINA, so all the nerves coming out from the bottom. So if we get a compression of these nerves, so either something in the spinal canal, or maybe a tumour growing into it, or maybe a slipped disc, a prolapsed disc compressing on the nerves. So this will cause loss of function in the legs and the pelvis, so it can lead to incontinence of the bladder and the bowels.
Stick your finger up his ass.
Normal procedure is to get an MRI.
Normal procedure for anyone coming in with these symptoms, you do a full history and want to do a full examination of the lower limb, of the legs. I'm assuming this has been done.
An MRI would take hours and delay steroid treatment and surgery. A loose rectum means his legs may give out soon. Tight means there's no paralysis, so we need to know exactly how tight it is up there.
This is a really good example of having good communication skills as a doctor, because imagine you come into hospital with back pain and, you know, a little bit of tingling in your legs, and the first thing the doctor sort of talks to you about is, you know, we'll need to put a finger up your bottom. You'd think, you know, the problem's in my back, doctor, not in my bottom. Doctors using Tinder definitely happens. We've got some doctor action in the on-call room. This is becoming a bit of a cliche actually, isn't it? It appeared in the first episode of Good Doctor and the first episode of Scrubs, and now the resident. Still never me, sadly. Although I got a comment from a security guard on my channel, let me find it. Sex happens on the night shift. I'm a medical security guard. Patients, doctors, clinical staff, random homeless people, teenagers, pretty much anyone. Yeah, well there you have it. Pretty small point here, so maybe I'm being a bit petty, but why would an on-call room lock from the outside? It's just waiting for an accident. So a chemotherapy patient admitted with neutropenia and an infection. I've seen this a few times. This is really nasty, and it can lead to neutropenic sepsis, which can be life-threatening. Many cancers involve fast-growing cells, so we have chemotherapy drugs that target just fast-growing cells. The knock-on effect is they actually damage our healthy cells as well. So they damage our hair follicles, meaning the hair will fall out, and the mucous membrane, so in our mouth and in our gut system, so that's why we can get bleeding. They also damage our immune system, so the white blood cells. So this means people are more likely to get infections, and when they do, they're more likely to be life-threatening.
It's just another infection. Chemo's still crushing your immune system.
Throw into the fact as well that these patients are generally unwell from the disease burden of the cancer, so we don't wait for any investigations before starting treatment of antibiotics and fluids.
Get you started on broad-spectrum antibiotics again.
And looking for a source of the infection.
Get cultures from both arms. Urine, she'll need a head CT.
We call this neutropenia because neutrophils are some of the white blood cells, and penia mean fewer of. This is most likely to happen a week or 2 weeks after chemotherapy, like was shown in the resident.
Last chemo was a week ago.
So Dr. Hawkins finds out about the death of the patient with the appendectomy. He's having a few choice words with Dr. Bell.
I'll be one of those celebrity TV doctors. You look the part.
And having to go at TV doctors. I know I'm not a TV doctor, right? YouTube is totally different. Gangrenous toes, I've seen loads of these. Must be so scary for the patient. I mean, diabetes is a triple whammy for your feet. The high blood sugar levels damages your nerves, your blood vessels, and increase your risk of infection. The nerve damage in your feet we call peripheral neuropathy, which means you can no longer feel the sensation in your feet, so you end up walking a lot more harder, and this over time damages the tissue. You also can't feel if you've got stones or shoes that don't fit very well, and this ends up damaging the tissue as well. The high blood sugars also damage the blood vessels, so it means the tissue of the feet don't get very good blood supply and ulcers end up developing. Finally, the high blood sugar means increased risk of infection because the bacteria like this kind of rich environment, and this can mean the ulcers become infected. All of these things knock-on effect means we can get toes that look like this. I've seen some of these toes literally about to fall off.
Still fell off.
Chad, buddy, we are amputating the whole foot.
There's just no way to save this tissue. We often do an amputation just because you can't get good healing if you just take a little bit of the toe away, and also prevents the possibility of deep tissue infection in the bones and things that can be really, really serious. So unfortunately, amputation is the only option. Believe it or not, this type of robotic surgery actually exists. There's one in my hospital called the Da Vinci surgical system. Violent patients, super realistic. I got a reputation with the security team fairly early on as an A&E doctor because one night I had just so happened to pick up 3 violent patients.
See these? These are OSLER'S nodes. Caused by bacteria swarming in your blood and moving throughout your body. Classic for endocarditis, an infection of the heart valve.
At some point in medical school, you will get asked this question. What are the signs of infective endocarditis? So this is our heart. So have you ever wondered why blood doesn't clot in your heart? Well, one of the reasons is your heart has this beautifully smooth inner lining called the endocardium. People use IV drugs and a dirty needle. They can introduce bacteria into the bloodstream. This bacteria can travel around and can colonize the endocardium of the heart, so the valves and the nice soft inner lining. This is endocarditis. Colonization of the valves means that we get turbulent blood flow, and this causes a heart murmur. And because this is an infective process, we can also get fevers. It can lead to 3 signs that we see in the hands, all because something gets pumped by the heart to the hands and causes this effect. The first thing is little clots can be pumped from the heart and travel to the hand. These can be seen under the fingernails of things that we call splinter hemorrhages. Second thing is tiny bits of this bacteria can break off and get pumped around the body. If this gets stuck in the small blood vessels of the palms of the hand, we get things called Janeway lesions, which are kind of painless changes to the palm of the hand. And finally, because it's an infective process, our immune system might start attacking this bacteria. If part of these immune complexes break off and get sent around the body, they can get stuck in parts of the tissues of the hand, and these cause OSLER'S nodes, which are very painful and is what we see in the patient in the resident.
Chloe, baby!
Get a crash cart.
Come with me right now.
I'm not getting a pulse.
So our second cardiac arrest of the episode. Is this realistic? Although in each case the circumstances are pretty rare, I wouldn't expect each of those patients to go into an arrest, but things are unpredictable in medicine. But in terms of just the number of cardiac arrests, when you carry the on-call bleep, so we carry it for 12 hours when we work on the medical team, it can go off any number of times from 0 to about 10. So we can get a lot of these calls in one day, but not all of these are going to be cardiac arrests. The nursing staff and other medical staff on the wards are actually really good at identifying deteriorating patients. So we'll often see people when they're approaching an arrest, and so it's a lot better to treat someone before they get to an arrest rather than when they do. So the cardiac arrest call goes out. The delay in chest compressions makes it really hard to watch. As soon as you feel a pulse and there isn't one, you should start chest compressions immediately. The patient heart is not pumping, therefore there's no blood going around their body unless we're pumping it for them with chest compressions.
Get them out of here.
So nowadays we actually give the family the option to be present during CPR. It's said to help them deal with the seriousness of the situation. Getting a defibrillator on early is super important, so I like that a lot, but it happened before the bag valve mask was put on, which I haven't ever seen before. In a cardiac arrest, your heart can be in one of 4 rhythms: PEA or asystole, which don't benefit from a shock from a defibrillator, and VT and VF, which when shocked can go back into a normal rhythm.
What's the rhythm? PEA.
So this patient is in PEA, which stands for pulseless electrical activity. So this is a rhythm that the heart should be producing a pulse at, but isn't, so actually can encapsulate quite a wide range of different rhythms. Because the electrical activity is essentially normal, as we talked about a moment ago, this will not benefit from a shock from a defibrillator. Although the actual monitor shows asystole, which is no electrical activity of the heart. Lucky for them, we don't shock the heart in either asystole or PEA. So in both these scenarios, we'd give adrenaline, as Dr. Pravish does.
It's been 24 minutes. It's time to call the code.
No.
Calling when to stop the code usually doesn't fall to just one person. The doctor in charge will put it open to the whole team to see if it's appropriate, and everyone will agree. So the patient's heart rhythm is restored, but unfortunately only the brainstem is preserved, so the heart will continue to beat and maybe the patient will be able to breathe unassisted, but the patient will never regain consciousness. I've seen this a couple times in reality, actually, from suicide, so unsuccessful suicides, and you know, what can you say, it's heartbreaking, isn't it? Dr. Pravesh is called to see a patient in supraventricular tachycardia, which is a problem of the electrical activity of the heart causing a very fast heart rate.
We pushed adenosine 6 milligrams, then 12. She's still tacking away at 180.
This is very common. I've seen it lots of times, but not normally something that worries you as a doctor unless the patient's blood pressure starts dropping. So usually a fast heart rate means the heart becomes more efficient, but sometimes if the electrical activity is sort of out of control and the heart is beating really quickly, the heart can become less efficient and therefore can lower your blood pressure or, you know, give you signs of heart failure.
That won't work, Dr. Bell. She's going to have a heart attack.
A heart attack is not something I would be worrying about. They're sort of standing around like they don't know what they should be doing. There's clear protocols, luckily, for dealing with stuff like this. You know, they've done the medication, but it says if a patient is unstable, because they're unconscious in this scenario, then we should fast bleep an anaesthetist because we need to be performing an electric shock on the heart to restore it into normal rhythm. Instead, they chuck a load of ice water over the patient, and this is semi-realistic. So this is called a vagal maneuver. We generally only do this if the patient is stable though, and we do things like holding your breath or putting your head in a bucket of ice, and this works because there's a nerve called the vagus nerve which helps slow the heart rate down, and if we stimulate that through other means, so if we stimulate it by holding your breath or putting your head in a bucket of water, then this can sort of send a rush of activity to the heart to slow it down. Anyway, that vagus nerve maneuver is pretty cool though, isn't it? So this brings us to the last scene. This is one I just couldn't watch. So Dr. Hawkins sneaks back in and attempts to turn the ventilation machine off that the patient who had a cardiac arrest before is on. This is completely unethical, and you'd undoubtedly get struck off and have a criminal proceedings against you. Although I understand the public sometimes think that we do this type of thing as doctors. When I worked on palliative medicine and I had a couple of patients that were in their last few days of life, I had on occasion some relatives ask, you know, if there's anything we could do to try and bring about death sooner. So we don't do things like this as doctors. So that concludes the first episode of The Resident. As I said, it was full on. It's clearly supposed to be a thriller, isn't it? It's far from the best representation of medical professionals and doctors in particular, but I think people know that it's going for the darker, dramatic twists rather than realistic scenarios. So I hope you enjoyed my insight into the first episode. You may enjoy some of the other medical reviews I do, so why not check them out? I'm also doing a poll at the moment, which you can check out in the description below, so you can have a say on what other medical shows I look at next. Thank you so much again for all the support and watching the videos, and I'll see you next time. Goodbye.